Hello everyone, welcome to your lecture on pain assessment and the physiology of pain. These are the objectives that we will be covering in this lecture. What is the definition of pain? It's an unpleasant sensory and emotional experience associated with an actual episode of tissue damage or described in such a way. But what's important for us to always remember is that pain is always what a person says it is. Your pain assessment is based on what the patient says, right? Now, it's the two terms that we use in relation to pain are pain threshold, the point at which the person feels pain, and pain tolerance, the amount of pain a person is willing to bear. So nociceptive pain. Now this develops when functioning intact nerve fibers in your periphery, for example, your hands and legs, your fingers, and the CNS are stimulated. So nociceptors are the type of afferent neurons that have the ability to respond to a noxious stimuli or to a stimulus that would be noxious if prolonged. For example, nerve receptors located on the ends of your, small afferent neurons. They're all throughout your body, your skin, your muscle, and their responsibility is pain sensation. Non-nociceptors usually do not transmit pain signals. So what is the noxious stimuli that stimulates these neurons and these nociceptors in your body? The noxious stimuli include mechanical, for example, incisions, tumors, growths; thermal, for example, burns and frostbites; chemicals like toxins, chemotherapy, or infection with virus and bacteria. So all of these stimulate the, nociceptors to, sense pain. So substances that increase pain transmission and cause the inflammatory response. Now, when these are called substance P, prostaglandins, bradykinin, histamine. For example, when you get, cut by a nail, for example, in this picture, you get cut by a nail, then what happens? That these substances are released because of that noxious stimuli. The nail, in this case, which is the nail, right? You get cut by the nail, and then substance P, prostaglandins, bradykinin, histamine are all released. And these increase the pain transmission and cause the inflammatory process to start. Substances that decrease pain transmission and actually produce analgesia normally within your body are serotonin and endorphins. So how does this happen? This happens through the phases of nociception. There are 4 phases. The first one is transduction. So what happens is you get hit by the nail, right? You poke yourself with the nail, and then the tissue in that area releases those chemical substances that, increase pain transmission, right? What were those? Those were the, substance P, prostaglandins, histamine, bradykinin. So these get released, and they actually move through to go towards your spinal cord, and in your spinal cord, you have the ascending pathway and the descending pathway. Ascending pathway goes up up your spinal cord to your brain, and the descending pathway goes from the brain down to your periphery, down from the spinal cord, right? So what happens is when the transduction happens, then this action potential, the pain transmission, it moves along those fibers in the spinal cord, and once it gets to the spinal cord, it goes up the ascending pathway to the brain, where the pain is perceived. Then your brain perceives the pain and then sends a signal down the pathway the descending pathway, which then, signals the pain. So basically, the modulation phase, the perception phase, is where the brain, perceives the pain. And then, then stage 4 happens, where the neurons from the brainstem release neurotransmitters that block the pain impulse. These are your, serotonin and your endorphins, your endogenous opiates, things like that help your body, inhibit the pain response. So this is basically what this table here shows. First is the transduction. Noxious stimuli activates the nociceptors, and then that releases bradykinin, substance P, prostaglandin, histamine. These take the pain sensation to transmit them to the brain, and the brain perceives the pain signal, and through conscious awareness of the painful sensation, and the limbic system, which has the emotional response to the pain, somatosensory areas which categorize the sensation and say, okay, this is pain, right? These sensations are identified in these higher cortical structures as pain, and then this pain message is inhibited, right? And then the built-in mechanism slows down and stops the pain processing and the painful stimuli, and it inhibits this sensation. And these include serotonin, norepinephrine, neurotensin, GABA, endogenous opioids like B endorphins. All of these reduce the pain signal or get rid of it. So once the serotonin and all that gets released, then your body starts to get analgesia. Okay, so there are different theories of pain. First, we have the gate control theory of pain, where pain impulses can be modulated by transmission blocking action within the central nervous system. So they basically block those transmissions of those neurotransmitters, so your body never feels the pain. That's called gate control therapy. Then we also have neuropathic pain, right? This is caused by injury or dysfunction, lesions and stuff in your nerves from peripheral or central nervous system, resulting in impaired processing of sensory input. Nociceptive pain can change into neuropathic pain as well, right? So neuropathic pain occurs due to conditions such as diabetes, herpes, for example, shingles, HIV, sciatica, trigeminal neuralgia, phantom limb pain, chemotherapy pain, lesions in your central nervous system from a stroke or, tumors. So this can cause neuropathic pain. So there are different mechanisms. One you have the peripheral mechanism. It's the ability, for example, neuroplasticity, the ability of the peripheral and central nervous system to change both structure and function as a result of noxious stimuli. Then you have peripheral sensitization. It's the change of the number and location of the ion channels, sodium channels, that accumulate in the injured nociceptors. This produces a lower nerve depolarization threshold and increases response to stimuli. Then you have allodynia, pain stimulated by a stimulus that normally does not provoke pain, such as sometimes people, you touch, they get pain from a touch, which shouldn't produce pain. That's allodynia. Hyperalgesia is increasingly intense experience of pain resulting from the noxious stimuli. So this is basically caused from nerve damage, and because of chronic conditions such as diabetes mellitus. Then central nervous system, you have central sensitization, abnormal hyperexcitability of the central nervous system neurons in the spinal cord. It happens because of changes in incoming, barrages of nociceptors, and it results in an increased nociceptive neuron response. So the pain seems extreme, right? So all of these mechanisms basically excruciate the pain, like make it feel really bad. Then you have what sources of pain? What are the sources? You have visceral pain. This originates from the large internal organs, for example, the stomach, intestine, gallbladder, pancreas. Pain coming from these organs is very dull, deep, squeezing, cramping. It's like, your menstrual pain, right? For women, it's that cramping pain because it's from, deep organs. For example, urethral colic, acute appendicitis, ulcer pain, and then it's accompanied by nausea, vomiting, hypotension, restlessness. Then we have somatic pain. This originates from muscular tissue or body surfaces. This over here, this kind of pain is sharp, dull, and well localized. It's in one specific area, because that's where the damage happened, right? So deep somatic from blood vessels, joints, tendons, muscles, bones, from trauma, pressure, ischemia, where you don't have enough circulation, usually aching and throbbing. For example, pressure injuries, this is also somatic pain. Then you have cutaneous pain from skin surfaces or subcutaneous tissue. This is sharp and burning pain. Finally, we have referred pain. It's perceived in an area distant from the site of the stimuli. Pain can be acute and chronic. Acute pain results from tissue damage. For example, a nail going in your skin or a car accident or something like that. That's acute pain. It results generally abates as healing occurs. Right? Serves as a warning signal that something is wrong and needs attention. It temporarily lasts less than 6 months, caused by tissue injury from trauma, surgery, inflammation. It initiates a flight and fight response. So when you have acute pain, you have the response of flight and fight from the autonomic nervous system. What happens here? Your heart rate increases. You have shallow, rapid respirations. Your blood pressure increases. You start sweating. You get pallor. You become pale. Your pupils dilate, and you're filled with fear and anxiety. So this is acute pain. For example, something like trauma from a car accident. Then we have chronic pain that may or may not be time limited, but it persists beyond the usual course of tissue healing, longer than 6 months. 6 months, typically complex. There's no clear etiology cause. It's unresponsive to medical treatment. It's always there. It's chronic pain. It requires a multidisciplinary approach with integrative treatments. You can't just, give a pain medication and fix the problem. It requires a multidisciplinary approach with a lot of different interventions. So the types of chronic pain are neuropathic pain, resulting from, like we mentioned, damage to peripheral nerves caused by infection or disease. For example, shingles or diabetes. Then you have phantom pain. It occurs after surgical traumatic amputation of a limb, such as a breast, bladder, eye. So the patient is aware of the missing limb. For example, after a below-the-knee amputation, the patient knows that the limb is missing, but they still feel the pain from that limb. It's that burning, itching, tingling, pressure, stabbing pain, and it can be triggered by stressors. Then you have psychogenic pain, which is absence of a diagnosed physiological cause, because there's no diagnosed cause for the pain, but is triggered by emotions. Then we have cancer pain, caused by direct effects of the disease, for example, the cancer, or its treatment, or it's unrelated. It's just always there. It's chronic pain. Then other malignant pain, HIV, burns, cancer pain, other, malignant pain requiring aggressive treatment. Symptoms that can be associated with chronic pain include depression, anxiety, despair, hopelessness, and fatigue. It is not easy living with pain, chronic pain that lasts for longer than 6 months and actually has no time limit. It can just last and last forever. What are the effects of pain on our body? Right? These over here, please go over this table. These are the different, effects that pain has on our body. These are some test your knowledge questions in these slides. Please go ahead and, read over this, and we can discuss the answers in class. How do we assess pain? Initial pain assessment. The most important assessment of pain is the patient, is the patient's, verbalization of the pain, the verbal report of pain from the patient. Ask the patient about their pain. We use the OPQRST method, right? We ask them, when did it start? What was the onset? What provokes it? Describe the quality of it. Is it burning? Is it sharp? Is it dull? Is it cramping? What kind of, what quality is it? What is the quantity of pain? Like how long, how intense is it? Then you want to know, where is it? Does it radiate to other parts of your body? What's the severity out of for example, 0 to 10? How severe is that pain? And timing, how long does it last when it comes, So those are extremely important ways of assessing pain for a patient, right? And ask them about how it affects their quality of life, how it affects their activities of daily living, their functioning. And find out, what is their comfort function goal, right? Acute pain, for example, identify short-term functional goals to reinforce good pain control. With chronic pain, identify functional quality of life goals. For example, how much pain are you willing to tolerate, right? It's not a challenge. We're just saying, okay, how much pain can you tolerate without it affecting your functionality? Like, can you function with a pain level of 2 out of 10, right? Or is that difficult for you? Does it slow you down? Does it stop you from doing your activities of daily living? So that's what functional goals, comfort functional goals are for. Then get other information, the patient's culture, past pain experience, comorbidities, labs and diagnostic studies, whatever is available, assess all of that. Now, what are some barriers to pain relief? Right? For example, nurse-related, inadequate knowledge of pain, suboptimal pain assessment techniques, right? Nurses need to learn to assess pain, well. Concerns of client addiction, like sometimes nurses are hesitant to administer analgesics because they feel the client is going to get addicted, right? Concern of adverse effects, they're afraid of the adverse effects from the pain medication. Concern of client developing tolerance. They sometimes are hesitant because they're afraid that the client will become tolerant and they're going to require more and more medication. And then they also consider the cost to the system. Okay, I'm giving them so much pain medication, it's costing a lot, right? Those are from the nurse's perspective. What about the client's perspective? What barriers can clients create to good pain relief? Their reluctance to report pain, their reluctance to take medication. Some people are scared, oh, I'm going to get addicted, and so I don't want to take it, The concern of being the complainer, like I don't want to become that patient, That concern can also create a barrier to pain relief. Cultural and ethnic background, the taboo of pain. For example, in some cultures, when somebody complains of pain, it's considered a sign of weakness. And because of that, they will, they just kind of learn to live with it instead of trying to get relief. Concern about adverse effects, concern about developing tolerance or addiction. And then the cost of the medication, they're afraid, okay, it's going to cost a lot for me to, buy this medication, so they just don't take it. Pain history. How do we assess the pain history of the patient? Self-report, family report, tolerance, willingness to endure pain. You ask all those questions. Sometimes family can be a really good resource when answering those questions. Their reluctance to pain, cultural biases, alternative pain verbiage like discomfort, distress, hurt, ache. These are some of the verbiage they use instead of, okay, I'm in pain. Location of pain may have multiple sites. They might say that their pain is all over. Intensity of pain, when you use a standardized scale, you're able to quantify the pain. Quality of pain, nociceptive pain, damage to the bones, soft tissues, internal organs. Is it somatic? Is it visceral? Is it neuropathic? Find out what kind of pain it is when you're collecting their pain history. Pattern of the pain. Get the baseline. Is it always there? Do you have like breakthrough pain? Like, is your pain like out of 5 and then all of a sudden something triggers it and it becomes like a 10 out of 10? And, aggravating, alleviating factors, history of pain medication and herbal supplements and cultural beliefs, expectations. They're different tools. What are the tools we use for pain assessment? They're different ones. You have the numeric rating scale, 0 to 10 point scale with word anchors of no pain at the end of the scale. And this is the best possible, way to collect, the severity, of the pain. Ask the patient, out of 0 to 10, how much would you rate your pain? Right? Then if the patient is nonverbal, or for adults and children over 3 years, but the patient, they're not able to express the pain on a 0 to 10 scale, you could use the Wong-Baker FACES scale. The FACES pain scale, revised, consistent with other scales, has 0 to 10. Then you have the visual analog scale, the CRIES pain scale for use with neonates and infants from 0 to 6. We also have different tools that for example, we use in the ICU to also assess pain. Pain assessment tools for the nonverbal patient. They're in a hierarchy of pain measure. Attempt to self-report first. First, try to find out from the patient what their pain is. If you can't, consider the underlying pathology. What could be causing the pain? Okay, is it a surgery they had on their abdomen, and so they have an incision? Maybe that's what's causing the pain. Evaluate the physiologic indicators. Conduct an analgesic trial. Start off with the least possible amount and see if that works. If it doesn't, then increase. And if it doesn't, then increase. Sometimes you have combinations of medications. So, and doctors will consider all of this too. Pain assessment tools, for example, they're patterned after the FLAC scale. The CPOT is a pain assessment scale we use in critical care patients who cannot self-report their pain. They cannot tell us because they're, they're not responsive. And so we use that pain scale for them. And then we have the pain assessment in advanced dementia patients that we call the pain AD scale. This is for adults who have advanced dementia who are not able to verbalize their pain. Then we have, that's the pain AD scale, that's the CPOT scale over here. This is the FLAC scale, where we use this for kids, face, legs, activities, cryoconsolability. The physical exam. Once you collect, the pain history and get the severity of the pain, try to quantify it, you do a physical exam. Observe for nonverbal cues, for example, withdrawal, fatigue, grimacing, moaning, irritability. Examine the sites of the pain. If there is trauma, injury, skin breakdown, bony structures, palpate for tenderness. Assess the area where the pain is, if that's what's causing the pain. Then auscultate for abnormal breath sounds, crackles, rhonchi, decreased breath sounds, pneumonia, abnormal bowel sounds like hyperactive, if there's an obstruction. Conduct a neurologic exam. Evaluate their sensory and motor, any sensory or motor loss, change in reflexes. Then it's extremely important that once you assess the pain, complete your interventions, you reassess pain. This is part of your evaluation, right? After initiation of pain management plan, pain is reassessed and documented on a regular basis. With every change in analgesic regimen, each new report of pain before and after administration of analgesics. If the patient says they have a headache of a 3 out of 10, and according to their medical administration record, they can take a Tylenol, you give them the Tylenol, then reassess the pain, see if it worked. Don't just say, okay, bye, I gave you the medication. No, you have to reassess it, right? And, for example, you can reassess for IV medications 15 to 30 minutes later. Oral medication, 1 to 2 hours later, it should have reached its peak where they actually feel relief. Use the same pain scale you used to rate the pain initially. So if you ask the patient how much their pain was out of a 0 to 10 numeric scale, say they set a 6, you gave them the medication, come back and use the same scale. Don't change the scale on them. Use the same scale out of 0 to 10. Now, how much would you rate your pain? Right? You can also assess using a, 0% to 100% scale if the patient has difficulty trying to comprehend out of 10, You can document pain scores and OPQRST. Make sure you document all of it. Now, these are what factors affect pain experience. Age. Infants can't verbalize their pain. Older adult clients have multiple pathologies that cause pain and limit their function. We want them to be functional, and pain should not be a barrier in their functionality. Fatigue, increased sensitivity to pain. So when you're extremely exhausted, for example, you had a long day at work, you pulled a 12-hour shift, you're extremely tired, and when you're exhausted, it almost feels like you're in pain, and so that could affect pain, your pain level as well. Genetic sensitivity, increased, your pain tolerance could be, genetically related. Cognitive function, might not be able to report pain accurately. That will affect your pain experience. Your prior experiences, for example, your sensitivity to the pain based on your prior experiences. That also is a factor that can affect your current pain experience. Anxiety and fear. It increases sensitivity to pain. Your pain seems even more when you're anxious and you're afraid. Support system and coping styles. Having a good support system and being able to cope, it actually decreases sensitivity to pain. You're able to function with, tolerate more pain than you usually can. Culture can influence expression of pain, and that can affect your pain experience. Non-pharmacological methods of pain management. Now remember, when a patient is in pain, it's not just about giving them medications, pain medications. There are other things you can do as well. You have physical modalities, cognitive behavioral methods, movement therapy, biologically based therapies, energy therapies. Please read over this in your PowerPoint. So non-pharmacological techniques can be cutaneous stimulations, basically a back rub, a massage, kneading or pulling, pressing, gently stimulating the subcutaneous tissue. You use some lotion or, and then you give them a back rub, and that helps with the pain. Relaxation and mindfulness. Activities to develop deeply relax can help to deeply relax the body and the mind, which is mindfulness. It provides a distraction. It helps you breathe better, which improves oxygenation, right? And helps with tension. You can use guided imagery. You can use distraction, where the client focus on something other than a painful stimuli. Now, acupuncture, biofeedback, transcutaneous, physical therapy uses this with their patients as well, calls the TENS, transcutaneous electric nerve stimulations. It's battery operated. They put these electrodes on and, they stimulate the nerve fibers. Now, the thing is, with non-pharmacological techniques, this works great with chronic pain, not with acute pain. If you're in the ER, a patient comes into the ER after a car crash, and you see a broken bone, exposed bone, and you're telling them, okay, let's use relaxation and mindfulness, let's use distraction. Okay, that's not going to cut it in a situation like that. In that situation, you definitely need more aggressive treatment, like pharmacological treatment. So for chronic pain, though, non-pharmacological techniques work great. Okay, this is a video. It's in your PowerPoint. Please give it a try. It actually is pretty good. It's a 10-minute video, on mindfulness. Then we have heat and cold therapy, and we're going to practice this in Skills Lab. What heat does is it vasodilates. It dilates your peripheral vessels, accelerates the inflammatory response to promote healing. You get increased tissue metabolism, reduced blood viscosity, like thickness of the blood, increased cardiac output. It's used to treat muscle aches, joint pain, spasm, itching, and rectal pain. Sources, you use warm, moist compresses, heating pads, immersion in water, plastic wrap to retain heat, aquathermia pads, sitz baths, and warm soaks. And then with cold therapy causes vasoconstriction. It constricts the blood vessels, reduces muscle spasms, and promotes comfort. It reduces blood flow to the tissue and decreases pain substances like histamine and serotonin, because remember, these were the substances that, increase the pain response. Then reduced edema, inflammation, and bleeding. Used for direct trauma, dental pain, muscle spasms, sprains, chronic pain. Sources are ice bags, cold packs, cold compresses, gel packs. Sometimes you can even tell patients who don't have these things to use like frozen vegetable bags, like Ziploc bags with ice, water, slush, soaked towels. There are some precautions you have to always be careful of, right? These therapies should not be continued if pain is increasing. For example, you use heat therapy and the pain is increasing, then stop. It's not working. Okay, it should neither be too hot or too cold. You don't want extreme temperatures. You cover heat and cold source with a towel for insulating to protect the skin. You don't take a hot, pad or like a ice pack and put it directly over the skin. You don't take ice and put it directly over the skin. You want to cover it in a towel or something to protect the skin from the direct contact of the ice. This moisture increases the effect or intensity. Do not use heat on areas that are bleeding, have recent injury, or have menthol oil on them. Don't put heat over there, because what it does, it dilates the vessels and they're going to bleed more. It's going to increase the bleeding. Do not use cold on areas that have poor circulation. For patients who have poor circulation, for example, in their legs, say they have circulatory problems, they have, vessels that are, not the most efficient, they have peripheral vascular disease or arterial disease. Don't use cold, because what it's going to do is going to constrict those vessels and it's going to block the circulation and perfusion to those areas. Heat and cold, is applied for 10 to 20 minutes at a time. Anything longer can cause, even more pain, and irritation. If it cannot be placed directly on the painful area, apply it to the opposite side of the body or above or below it. That also can help. But always remember, prolonged cold exposure can cause increased blood pressure, shivering, goosebumps, and tissue injury. And prolonged heat exposure, more than 20 to 30 minutes, leads actually to vasoconstriction, because if you remember, heat therapy causes vasodilation, but prolonged heat therapy can actually cause vasoconstriction, right? And so you don't want to keep it there for longer than 10 to 20 minutes at a time. Okay, nursing considerations with non-pharmacological therapies. Concurrent use of analgesics should complement, not replace. These complement pharmacological methods, right? You give the pain medication and then implement these strategies as well. Your attitude toward non-pharmaceutical methods. Energy level. Assess the energy level, degree of fatigue, ability to understand and follow directions. Involve the family and caregiver in treatment. Provide adequate instructions to support materials in different forms, audio, visual, whatever is easy, whatever makes it easy for them to understand. Refer clients to different therapies of interest that they want, like for example, meditation, yoga, tai chi, any of those that they would be interested in. Now, what are the different nursing diagnoses related to pain? We have acute pain, chronic pain, altered comfort. These are some other, nursing diagnoses that you can, use depending on your patient's situation, of course. Clients who are at risk for poor pain assessment and treatment are children, older adults, cognitively impaired, patients with language barriers, cultural and social attitudes, lack of knowledge, fear of addiction, and history of substance use. It can create bias. These are some questions. Please go ahead and review them, and I will provide you with the answers in class.